Good evening, everyone. Myself, Dr. Deepak, consultant medical oncologist in GSL Trust Cancer Hospital and Ayodhya Cancer Center from Rajahmundry, Andhra Pradesh. So, my talk in the next 20 minutes will be on various aspects of head and neck cancer and COVID-19. It is a powerful reminder to all of us that together our choices and actions have the power to protect the most vulnerable among us in a big way. The same holds true when it comes to cancer. We all must join our hands together to prevent, to detect cancer in the early stages and as well as in the management. Yeah. With the ongoing demographic and epidemiological transition, now cancer is emerging as a major public health concern and is a major cause of morbidity and mortality in developing as well as in developed countries. And specialization not only in oncology and in any field has no doubt raised the standards of care of patients. But for a common man, getting right treatment for cancer is a big challenge, especially due to the finances involved in it. And not only the finances, especially in our society, the stigma with which a patient with cancer will be labeled is a major hurdle. And if you compare our Indian data with the world, most common cancer in both genders is breast, followed by lung worldwide, as well in India is the head and neck cancer. And if you see data only in males, worldwide, lung cancer is the most common carcinoma, followed by prostate. But if you see our statistics in India, head and neck cancer is the most common cancer, followed by lung. Lung cancer now accounts for the second most common cancer after head and neck cancer. And in females, the most common cancer is breast, followed by colorectal worldwide. But in India, second most common of cancer after breast is carcinoma of the cervix. Coming to head and neck cancer, in next few minutes, I will talk on these topics like introduction, epidemiology, and what are the various risk factors for head and neck cancer, and how they will present to us, and how to evaluate such patients, and brief on staging as well as management. Coming to introduction, as I said in the prior slide, it is the leading cause of rise in cancer incidence and mortality worldwide, and 5 years survival will be around 10 to 50%. For those who present in advanced stages like metastatic stage 4 disease or who develop recurrence, they will carry a bad prognosis with a survival of around 6 to 9 months. And there are many newer approaches, and now we are shifting more often towards molecular level. Coming to epidemiology, incidence is around 9 in 1 lakh of patient population, and highest incidence of nasopharyngeal subset occurs in Nagaland. If you see the 5-year survival of head and neck cancer patients, if you take all stages combined, it is around 65%. Suppose if you take only the localized disease, 5-year survival of such patients will be more than 80%. And if you see the data of local regional disease, it is around 63%. And those who present distant metastasis, it is around 36%. Yeah. And coming to head and neck subsets, and head and neck cancer is not a single entity. It includes heterogeneous group of tumors of varying primary size. And 95% of them are squamous cell carcinomas. And various subsets are oral cavity, pharynx, and larynx. In the pharynx, again, there will be 3 subsets like nasopharynx, oropharynx, and hypopharynx. Other subsets of head and neck cancer from where the carcinogenesis can begin are paranasal sinuses, salivary glands, as well as in the lip. Coming to oral cavity, malignancy can start from any of these subsets like lip, either gingival sulcus, hard palate, soft palate, uvula, either from the tonsil, buccal mucosa, tongue, or from the floor of the mouth. Coming to pharynx, again there are 3 subsets like nasopharynx, which extends from the base of the skull up to the soft palate inferiorly. Oropharynx, again from the soft palate superiorly up to the valvular inferiorly, and hypopharynx extends from valvular to the cricoid cartilage. All the malignancy can develop from the larynx, and these are the various subsets like epiglottis, sophoglotis, vocaloid, glottis, or subglottis. If you see the most common subset worldwide, it is the tongue. if you see our Indian data, the most common subset in the oral cavity is buccal mucosa. Coming to risk factors, and as we all know, these are the most common risk factors like tobacco use and alcohol. Next slide. And smoking tobacco products like cigarettes, cigars, pipes is an important risk factor for development of head and neck cancer. And in heavy cigarette smokers, there is almost 5 to 25-fold increased risk of cancer compared with non-smokers. And definitely there appears to be a dose-response relationship. And these are some of the smokeless tobacco products like both chewing tobacco as well as snuff is associated with an increased risk of oral cavity and pharyngeal cancers. Next slide. And definitely alcohol consumption independently increases the risk of cancer, although it is often difficult to separate the effect of smoking and alcohol. And relative risk of developing head and neck cancer due to alcohol appears to be dose dependent. And alcohol intake and tobacco chewing or smoking appears to have an interactive and multiplicative effect on the risk of developing head and neck cancers. And now we are establishing some viruses as the etiology of head and neck cancer, especially oropharyngeal cancers like human papillomavirus, Epstein-Barr virus, HSV, and HC. Next slide. And these are various other risk factors like poor dental hygiene, constant trauma to the mucosa of oral cavity or pharynx, and radiation exposure. Some of the hereditary syndromes like Bases and Evers syndrome and xeroderma pigmentosa, and pre-malignant conditions like lichen planus, erythropakia, leukoplakia, and chronic candidiasis, and malnutrition. Next slide, please. And how we diagnose such patients, especially it's based on symptoms. Some may present with a white patch in the oral mucosa, or some may present with a swelling somewhere in the oral cavity. And most often, many patients will present with some swelling in the neck region. Next slide. And these are some of the common clinical presentations like white or red patch, either on the lip or in the oral cavity or lump over the neck. Next slide. And some may present difficulty in swallowing. And one more usual presentation is long-lasting sore throat. Normally, if such patient present to us, we'll give a course of antibiotics for 2 weeks. Even after that, if it is persistent, then we will evaluate such patients based on their risk factors in view of malignancies. Yeah, next slide, please. And these are other common presentations like robust pharyngeus, sore throat, and earache. Next slide. And some may present with western nasal discharge, double vision due to involvement of the cranial nerves, and headache. Next slide. And if recurrent pharyngeal nerve or some other thing is involved, some may present with change in voice like hoarseness and weight loss. Yeah. And these are the pre-cancerous condition. Coming to erythropakia, you can see like it appears as a fiery red-covered, sharply demarcated patch, and most often it is located on the floor of the mouth or on the tongue region or the soft palate, and it carries a risk of malignancy. And surgical excision is the mainstay of treatment for such pre-malignant conditions. And in the right-hand picture, you can see a white patch in the buccal mucosa, and we call it as leukoplakia, and relatively common manifestation, and is almost benign, but eventually there may be a chance of developing squamous cell carcinomas. Yeah. Next slide. Coming to oral submucosal fibrosis is a chronic progressive pre-malignant condition and is usually characterized by submucosal fibrosis involving all of the oral submucosa. It commonly occurs in those who choose alternates and as well as in those who choose span. Yeah, next slide, please. And these are some of the precancerous conditions like verrucous leukoplakia, which can occur over the hot palate and alveolar region. And this is one example of heavy leukoplakia over the tongue region. Yeah. And how do we work up such patients? And mostly we will take the history followed by physical examination. First, what we will do is we will usually inspect all of the oral cavity using a light and a mirror for clear view, and we will palpate the oral cavity to the maximum extent possible, and we should not forget to palpate the neck region for any palpable lymphadenopathy, lymph nodes. And coming to endoscopy, suppose if there is no evident tumor in the oral cavity, then we will proceed for either laryngoscopy or pan endoscopy. And at the same time, we will take help of the imaging, like we suggest such patients either to CT scan or MRI scan. And for metastatic workup, in order to see disease, like whether there is any disease is there, we will suggest such patient to chest X-ray or CT scan of the chest along with ultrasound of the abdomen. Yeah, that's it. And for HPV testing, these are some of the gold standard tests. Gold standard is either by HPV DNA testing by in situ hybridization or RT-PCR. Suppose if such facility is not there, we will subject for immunohistochemistry of P16. Yeah, next slide, please. And for staging, localization staging, we will use either contrast CT or contrast MRI to see the disease extent. And for some patients, we will offer PET-CT, especially for those who are having high burden of disease. And some patients are present with only swellings in the neck region. Suppose if there is no tumor evident on extensive evaluation, we will subject such patients for PET-CT. And suppose if the patient develops again recurrence, we will see for distant metastasis with the help of PET-CT scan. Next slide, please. And as I said before, we will do nasopharyngoscopy along with triple endoscopy. Yeah. Next slide, please. And this is in brief regarding the workup. And we will offer physical examination. We will take a good medical history, dental examination, and we will do the needed blood test. And final diagnosis will be based on the biopsy from the suspicious site. And for the staging, we will do CECT or MRI scan, and followed by PET-CT in some patients. Next slide, please. And final diagnosis will be based on the pathology report. We will take biopsy from the primary site as well as from the lymph node region. And histopathology will confirm the diagnosis of cancer and reveal specific characteristics of the tumor. Yeah, next slide. And most common histology will be the squamous cell carcinoma, and more aggressive will be basiloid cell and spindle cell carcinomas, and less aggressive will be the papillary and verrucous carcinoma. Yeah, next slide. And coming to staging, next please. Suppose if the cancer cells are limited only to the mucosal lining, then we will call it a stage 0. Suppose if the tumor is less than 2 centimeter and it has not spread beyond that primary site, then we will call it a stage 1 disease. Next please. If the tumor is 2 to 4 centimeter, we will able to test stage 2 disease. Suppose if the tumor is more than 4 centimeter or there is a palpable node in the neck region, then we will able to test stage 3 disease. Next, please. Suppose if the tumor has spread to the surrounding muscles, or if there are bilateral lymph nodes, or if the lymph node size is 3 to 6 centimeter, then we will call it a stage 4A disease. And next slide, please. And if it has spread beyond the local site, suppose, example, if it has spread to the base of the skull region or to the area surrounding the major vessels, then we will call it a stage 4B disease. Suppose if there is evident or distant spread to the lymph nodes, either to the lungs or to the bones or to the liver, then we will call it a stage 4C disease. Yeah, coming to modalities of treatment, there will be 3 main modalities like surgery, radiotherapy, and chemotherapy. As far as possible, we will offer surgery, especially to the carcinomas which are arising from the oral cavity region, because mostly they will be easily accessible, and there will be a possibility of simultaneous rejection of the tumor as well as reconstruction can be accomplished with acceptable functional outcomes. But however, oral cavity malignancies will be locally aggressive, and even though we subject them for surgery, for many patients, there may be a need for radiotherapy after the surgery. Suppose if the carcinoma is arising in the oropharynx or hypopharynx or larynx, we will try for organ sparing surgeries, but most of the times we will subject such patients to definitely radiotherapy along with chemotherapy. When to operate? The ultimate goal of surgery management of a primary head and neck cancer is we have to try to completely reject the tumor as far as possible, and we have to try for immediate reconstruction. So with both this, we can attain a socially acceptable level of function and cosmosis. Next slide, please. And there will be many decision-making process, like we have to see the tumor factors, like how big the tumor is and whether the lymph nodes are involved or not, whether the complete resection is possible, whether the reconstruction is possible, and patient factors like how fit the patient is, whether he's having any comorbidities, and all those things we have to take into consideration by subjecting patient for surgery. Yeah, next slide, please. Coming to radiotherapy, there will be two modalities like external beam radiotherapy or interstitial brachytherapy. Next slide, please. External beam radiotherapy is nothing but we will give radiation which will be produced by a mission which is kept outside the body, and it will be aimed at the tumor. And it usually done as an outpatient procedure. Coming to internal radiation therapy or interstitial brachytherapy, we will insert some of the pellets or rods which contain radioactive materials, and we will surgically place them in the cancer site or near the cancer site. And to that port, we will deliver the radiation. Next slide, please. Coming to the systemic therapy, most common treatment we offer for advanced oral head and neck malignancies are those who develop recurrence with the chemotherapy. And nowadays, we are offering explaining the patients regarding targeted therapy and immunotherapy. Next slide, please. Coming to chemotherapy, chemotherapy is nothing but we will give the through the vein, and usually the chemotherapy acts by destroying the cancer cells, like whether it can affect the growing, dividing cells in our body. Next slide, please. Coming to targeted therapy is nothing but we use specific agents which will target specific genes, proteins, or the tissue microenvironment that contributes to cancer growth and survival. The main advantage is targeted therapy is it will limit damage to the healthy cells. But one of the disadvantages, we may not find targeted therapy for some of the patients. Yeah, next slide, please. Coming to immunotherapy, we will otherwise call it as biological therapy. It is nothing but it is designed to boost the body's natural defenses to fight the cancer. And a few examples which we use in head and neck cancers are pembrolizumab and nivolumab. And we will give immunotherapy either with chemotherapy or for those patients who are not fit for chemotherapy, we can subject them for single agent immunotherapy. So as I said, these are some of the few examples like pembrolizumab and nivolumab, which will target PD-L1 receptors in our body. And head and neck cancer management is not a one-man show. There will be many people involved in it, like medical oncologists, surgical oncologists, radiation oncologists, with the help of anesthesia team. And with there must be help from the nuclear physician, gastroenterologist, radiologist, pathologist, as well as the orthopedic department. Next slide, please. And we will take help of other specialties like general medicine, surgery, and oncology. Nurse plays a key role in management of head and neck malignancies, and other specialties are physical therapists, ENT specialists, psychiatrists, and social workers. Coming to prevention, as we have seen the various causes of head and neck cancer, we have to advise to each and every patient as well as the bystander to avoid the use of tobacco products either in the inhalation form or in the chewing form. And we have to avoid the alcohol and other things that we have to limit exposure to ultraviolet light, and we have to maintain a healthy weight and eating patterns. Yeah. And these are the various preventive steps, like we have to limit tobacco product uses as well as alcohol uses. And we have to detect it in the early stages of like self-examination. And we have to avoid the radiation exposure, and we have to use sunscreen wherever it is needed, and we have to go for frequent dental checkups. Yeah, next slide, please. And definitely, now we are having facilities everywhere, not only in Taiwan cities, as well as in Type 1, Type 3 cities. And definitely, we have to detect every cancer in the very early stages, because every detection saves lives. Yeah, next slide, please. And prevention is always better than cure. And next step is every detection is always better than late detection. And cancer not only affects the individuals, but it also affects the entire family. So we have to try to detect or prevent in the early stages itself. And these are some of the awareness programs which we have conducted to the local Anganwadi workers regarding breast cancer as well as head and neck cancers. And these are some of the awareness camps which we will conduct regularly in some of the less penetrated areas in our society. Like this is a central prison in Rajahmundry. This is a prison for women. And thank you one and all, and especially thanks for the Hetero team.